Hello, everybody. Welcome to another segment of Pulp Nonfiction. With me today, I have Dr. Krystine Sambor, a family physician here in the Lower Mainland. Krystine sits on the North Shore Division of Family Proactive COVID Task Force and also part of a peer mentorship group for physicians. She's on the cusp of what's new with COVID in the Lower Mainland, and I believe you have a lot of valuable information that you can share with us. I really look forward to hearing more from you.
Thanks, Joel. And I don't know if I ever knew I'd be an expert in this, but just as way of background, I am the medical director for a large family practice unit in North Vancouver. So because that's a bit of the epicenter of most of the cases, we've been really the first to try to work through things and then trying to get that information out to other communities, as we're usually about a week or two ahead when it comes to troubles and different things that we're doing in the community.
Yes. The North Shore, if people are not from the Lower Mainland, the North Shore has a little hot spot for COVID in that old folks home, and that's right on your doorstep.
See it out the window right now. So the first death from COVID in Canada happened about a kilometer from my house.
Oh, yes, that's getting a little too close to home. So, can you give us an up-to-date an idea of the situation here in British Columbia and then perhaps in Canada?
So I think it is actually important to know what our strategy has been in British Columbia. I do think public health has been doing quite a good job initially of kind of managing compared to other jurisdictions. So when the virus first started coming to light in China, China had some very aggressive measures, and it really bought us a lot of time to get our structures in place. So there was a couple of different phases for an epidemic, and the first part of, we'll show you a little, everyone's probably seen this sort of flatten the curve picture. So initially, we did quite a good job of delaying. So the longer we can delay our first cases of community spread, the more time the healthcare system has to adjust. And so in the first phase is really containment. So we were very aggressively testing and contact tracing. Most of our cases were coming from out of the country from travel. And it was interesting because we were also decided that anyone that was swabbed for influenza early on also got a bonus COVID test if they were influenza negative. And it's actually how we found that first traveler from Iran, and that was a sentinel case for the entire world. We actually went back to Iran and said, you guys probably have a bit of a COVID problem, as they weren't really identified as a problem country. So at some point, I remember what week it was, we had done about 6,000 swabs, and all of the states had done about 400 at the same time. So our testing per capita had been quite high in that range. Just around spring break, though, we realized that people are going to be traveling and coming back. So we changed the strategy a little bit. And anyone that came in that had traveled was asked to self-isolate. And we were actually getting a bit inundated with swabs by that time, so it was impossible to test everyone. So starting last week, we changed the strategy again, and we asked anyone with even mild symptoms to stay home for 14 days. And we were really just testing now healthcare workers, long-term care facilities, and if people are sick enough to be admitted to hospital, they're tested. And then clusters. So one of those clusters would have been the PDC, where we're specifically trying to contact trace in that case.
And the PDC for outside listeners of the Pacific Dental Conference, which was held in Vancouver in early March.
How many dentists?
15,000, I believe.
15,000 dentists, and there was somebody that was positive. And of course, I can't remember the final numbers, but there's about 30 or 40 cases that were related to that conference. And that's just locally. Of course, people traveled on back to their other provinces and countries.
Yeah, I just because some people are not familiar with everything. Yeah. Sorry, carry on.
No, it's okay. Where was I with that? And then as healthcare workers, by the way, that's still the strategy. And dentists are included in our healthcare fast track. So here locally in North Vancouver, our local hospital has a healthcare worker drop-in through the parking lot, and it's a quick little assessment, and those swabs are actually coming back usually in under 24 hours. And we would ask that if you are someone who is actively treating patients and have symptoms, that's a way for you to kind of get back into your clinical practice. We're asking healthcare workers that are not doing active clinical duties. Obviously, you know, we don't want to be using the resources if you're at home and not seeing patients, but regionally around BC, there should be somewhere in your community to get access to fast testing if you do develop respiratory symptoms. So we've done a nice job of sort of slowing things down, but we're just now starting to see a little escalation in our community cases. So this week, half of our new cases are now spread within the community and are not necessarily from travel. And so here's the part that's really important for us to all having like those aggressive social distancing measures. This is the time to do it. So you might have all heard that term flatten the curve. I mean, it's become just sort of a Twitter handle, but what does that really mean? So we want to make sure that we know that about 40 to 70% of population has to get sick with this at some point for us to have enough herd immunity for it to fizzle out, or we get a vaccine, so whatever comes first. If everyone gets sick all at once, then we won't have the capacity within the healthcare system to deal with that. If we can
like
slow
30
down.
times the number, 30 times the number of people would need hospital beds that are available if we did nothing.
Oh, yeah, and I have some numbers that we ran for BC. So if we have, so in BC we have 5 million people, right? So if we're just conservative and just say that 50% of people are going to get sick, so 2.5 million people are going to get sick. About 20% of those, 80% are going to have mild to moderate symptoms, can absolutely convalesce at home. It's not a big deal for them. 20% will need to be admitted, and even that's a lot because that's 500,000 people that need a hospital bed, and we certainly don't need, so not just supportive care and oxygen. Even that simple level may be difficult to manage. But if we assume about 5 to 10% of all those patients will require ICU and ventilation, so we're looking at anywhere from 125,000 to 250,000 patients that at some point will need to be ventilated, often for a week or more. And in the whole province, and you know, the numbers are kind of are changing, and we're getting more resources, but we currently have about 1,272 ventilators. So there's a big disconnect in the amount of people that are going to need a ventilator and how many we have at any one time. So when you look at those curves and you see like, what does it mean when we have a sharp curve? It means that all those people above the curve, you know, potentially it's going to be 1 to 2% of people that need to be ventilated will get a ventilator. And that's really what's happening in Italy is the mortality rate in those patients is very high, and physicians are having to choose who gets ventilated and who doesn't. So we're starting to actually have that conversation, the ethics about how we would manage that. So what would be better for us all is if everyone took social distancing very seriously, and if we really protected our vulnerable population, and people will get sick, but we want them to get sick just under our capacity, right? So we can kind of manage those patients over time, and it could take a year to 18 months. For us to kind of safely get through that system and have the healthcare system available. I talk often to younger patients as they say, oh, it's not my problem, I'm 20 and you know, I'm just going to get a flu, not a big deal. But the issue is that what we're seeing in places like Italy is all-cause mortality and morbidity go up. So you can be in a car accident or have an appendicitis, a dental abscess, and the healthcare system just won't be there for you. And so people are dying from things that normally we would have been able to handle quite well in the system. So that's why, you know, public health and the doctors are really pushing for people to understand what's at stake here when we talk about flattening the curve.
Mm-hmm. And with that in mind, social isolating, can you define that from your perspective? Because it's one thing to say it, but it's
Yeah.
another thing to understand it.
Yeah, there's different terms are being floated around. So we talk about the social isolation that we would ask our vulnerable patients to do, or sheltering in place is what they're calling it in the States. So anyone that has an older age or other risk factors really should not be leaving the house at all, and they should be getting everything brought to them. Versus, quarantine, like the people that came from travel, again, um, they should be at home. They should not be walking their dog. They should be fully at home and being provisioned by others or by delivering. Everyone else, there's different measures of social distancing. We keep kind of upping the ask. So right now, most people should be at home and really only making short trips for absolutely necessary things in the store or whatever. I know Bonnie Henry has said, we can probably be out in nature as long as we're giving each other a wide berth, and that's probably still okay for now. But certainly in the coming weeks, we might get to a point where any trip out of the house, I think you really have to think hard about whether that activity is worth it to you and your family. So there's different degrees of it, but certainly the vulnerable, and then the people that we've identified that would be risky as far as a carrier, someone that would develop symptoms, we would ask them to fully self-isolate. And it's interesting within families. So so there's some guidelines we give because we've had some interesting clusters locally of families, and you can self-isolate within your own home, right? So if you're in a family and you're COVID positive, we ask people to have their own bedroom, to have their own bathroom, obviously eat separately, be careful with your utensils. And in local clusters, the transmission rate within a family clusters are probably only about 30%. And it's usually more with the intimate partner, but the other family members, can actually isolate themselves enough that they don't always all get COVID positive. So we do have specific guidelines that we give to patients around that.
Okay, no, that's excellent information. Now, can you speak to a little bit about how you've been restricting your practice and some of the things that in medicine you're now just passing on, and some of the
It's come so fast.
and
Oh,
tough love you've been telling patients, because I think it'll help calibrate dentists. And
yeah.
this is not an emergency, and that one of the analogies I like to use is if you're on a desert island, would you be inclined to swim off that desert island because the pain is that bad into the shark-infested waters, or would it just be bad for your day, right?
I'm gonna start using that.
You got an ortho wire in your cheek. You know what? Get an
You
emery.
can probably deal with it. Yeah.
Yeah. But
Things are moving so fast, and again, we're probably experiencing it here more quicker than everywhere else. So this might even be news to other physicians in other parts of the province. But even like a week ago, it was maybe a week or a half ago, it was almost business as usual. And now we've gone to complete lockdown, which means we see every single patient virtually. And if somebody needs to be seen for something very urgent, then we make arrangements for them to come into the office, but it's only one physician, often no MOAs in the office. We ask people to wait in the car, so wait room in the car until we call them up. We are now on universal precaution, so to any kind of close contact with the patient, we all have a mask, eye protection, gloves, and then if anything closer than that, we put on full PPE. And we've had to make some tough choices. So things like allergy shots, people have been doing them for 2 years. We're going to have to just abandon them and start again at the other end. We're going to be deferring some of our even infant immunizations. We're not quite there yet, but when it gets really bad, I guess one of the arguments has been is we're all self-isolating anyway, so the chances of someone getting measles because they're all home together is probably pretty low. So we're doing the very early infant immunizations, and then anything after 2, we're certainly not doing in the office. So a group of 13, we maybe have like 2 or 3 people a day that are coming in. So yeah, so it's been very, very restricted, and we're finding we can actually we can manage a lot of that over the phone. But when you're trying, so what in the equivalent with dentistry, I think if you're trying to make a decision about whether you need to come in, I think there's two elements. So one is that principle of first do no harm, right? So I think about this all the time. If I want someone to come in to see me, especially if they're vulnerable, is it worth them coming through my community and coming to see me and risking getting infected? Um, and also medical legally down the road, if you've given that advice and we've been told nothing but urgent, and you've asked someone to come in and someone can make the argument that it wasn't urgent and they do get infected, there is actually a risk there, both ethically but also medical legally, I think. On the flip side, what we have found every day is people minimize their symptoms. So people blow through we have all of these protections in place. They get pre-screened on the phone. They have to walk through a maze of signs to even get in the door. Then they get pre-screened at the desk. They get pre-screened on the way to the room. I will be in with a patient and they will finally say, oh, well, I do actually have a bit of a cough, but I didn't want to freak everyone out. Okay, now I'm freaked out. So I suspect if someone has a really bad toothache, they're going to be quite motivated to increase the symptom of the toothache and minimize perhaps their symptoms, or people have lied about their travel history. And so I think that's why we've all gone to very much universal precautions. We're assuming certainly by next week, anyone coming through the door, and we've already started, but as community spread goes up, really anyone coming in your door could be a potential person that's infected.
Yes, no, it's that's absolutely true. Yeah, we really need to prioritize, and we need to medical and dental differentiate between the trauma, the true pain, and the drama, your ability to cope with the pain. And it rhymes. That's why I'm using it. I'm not trying to be derogatory towards the people, but some people's are very upset about a little bit of pain, and it's not an emergency. And this is this situation where you have to improve your practice management comes in really well. Is like, well, you know what, and you give them a perspective. You could come in and see me, but you are putting yourself at major risk. It sounds to me like you're going to be okay, and these are the things where it's not okay. So this and this and this develops, then yes, absolutely, you should call me, because those are bad signs. But right now, from what I hear, I think you're gonna be okay. And in the grand scheme of things, you're way better off enjoying your self-isolation and your safety. And that tooth is annoying, but at least you're healthy.
Yeah, I agree completely. So I have a lot of conversations with patients like, ideally we would do X, Y, and Z. However, there's this added element of risk or whatever. So we're going to do this instead. And these are the situations in which you need to get a hold of me so that we can make a decision if things worsen, right? So if we can temporize and delay. I mean, I think particularly right now, the next sort of 2, 3, 4 weeks will really tell us whether we've managed to be aggressive enough with our social distancing measures. And then there might be a time where we might loosen off a little bit of, the restrictions. And this is a marathon, not a sprint. So we have to, like right now, we're really wanting to slow down our trajectory. And I'll show you, I'll send you guys the, our current stats. I mean, if you look at it, it is kind of rising quite fast. I don't know if we're seeing the drop off just yet. And our cases are doubling, every 3-4 days. I haven't looked at the stats today, but and our ICU admissions are starting to climb. So I think that's why these next 2-3 weeks might be really crucial. Then we can catch our breath if we're able to bring that down, and then there might be a little bit more leeway. But that will be managed over time, and it could be over the long term, like 12 to 18 months, where we just things get better. We might let people do more, and then we might need to be more strict again. So that's kind of where we're at. So yeah, it's not forever, but it's for now.
I will speak to us about doffing and donning.
Sorry?
I'm not doffing and donning. I'm not talking about
Oh,
a.
the doffing and donning,
I'm
yeah.
not talking about a
So
figure skating couple in the Olympics, but doffer and
yeah.
don.
So, right. So whenever we're anywhere near a patient, so we still try to stay the 2 meters, but when I'm just taking a history and physical, which I'm not doing a lot of because I'm usually doing that virtually first. So I have just a surgical mask. I have goggles that are reusable but washable. I wear scrubs. I have gloves. If I need to come in closer to the patient, certainly if I'm taking their mask off, then we do everything. So I have like a hair cap. I have a visor, a fully down visor. We don't use N95s yet because we're not doing aerosolizing procedures, and I'll talk about that in just a sec. Full gown. And that's just to come in and do a swab, right, or to just look in somebody's throat. I'll send you pictures. A friend of mine sent me, she's an anesthesiologist, and they're getting fitted for the full out respirators to get anywhere when they're intubating, right? Which I'd assume that dentistry is probably more aerosolizing than intubating a patient. So yes, so N95 masks, definitely, and there's different types of N95 masks. There's the generic ones that are kind of a one size fits all. And then there's other ones that are there they are. There's hospital grade ones. I can't remember which company makes which, but that come in different sizes, and you need to be specifically tested for it. All our colleagues now are losing their mustaches and their beards. We don't recognize them because you can't have any facial hair for a N95 to actually work appropriately. To know you have a tight seal, you can get a bit of a nauseous substance or just something really strong smelling like mint or something, and see that once you have your mask on, can you smell it? And then if one of the strategies, if people are running a little bit low on N95s, the N95 is for your protection. And you could put a surgical mask, which we have more of, on top of your N95. So if you're planning to see more than one person and you need the N95 for your protection, just for cross-contamination, you can take that mask off, so that you can continue to use your N95, which is more for your protection. And then so the term donning and doffing is how, in what order do you put your gear on and take it off? And we do it quite a lot, but when it's a stressful situation, we've all kind of forgotten the steps. So I've posted it right on the wall for physicians, and I can send that to you. The donning is more, sure, go through the way that they say it. That's really to, and actually it probably is relevant because it's like, can I transfer something to the patient? And as healthcare workers, we're all going to be a little bit higher risk for potentially having mild symptoms. We would hope that those people would stay home, but when you're taking it off, it's a very specific, you don't want to accidentally, touch a mask and then touch it with your hand. And so you can have ways of kind of cross-contaminating yourself. So there are specific ways that we ask people in order, which order they take, and it's hand washing in between each step. So seems a bit OCD, but it's there for people's protection in an aerosol, especially if you're doing aerosolized procedures.
Hand wash for 20 seconds.
What's that?
Hand washing for 20 seconds.
Yes.
Happy birthday twice.
Happy birthday twice. Yeah. Yeah, there's actually a good reason for that.
I believe there's birthdays in your house.
Yeah. Well, we will doing lots of hand washing today with Chris's birthday. Perfect. So then there's reason for that. So this virus in particular has like a lipid type coating. So the soap is actually really good at just breaking down, any kind of fat. And then you need that mechanical washing as well, and that just breaks down the outer coating of the virus. So soap and water is actually extremely effective. We also the sanitizer, the hand sanitizer, has to be the right grade. I know so locally some really cool things are happening. So our distilleries have all switched their production to making hand sanitizer, which has been a bit of a learning curve for us because we had to figure out what percentage of alcohol they needed in the mixture, and they had to be sort of accredited that it would be actually useful. You do have to have enough on your hands that you're able to kind of still do that 10, 15, or 20 seconds, even with the alcohol. hand washing actually is better because you're mechanically removing some of that dirt. Yeah, and then for cleaning, there are some pretty good recommendations and guidelines around like what percentage of bleach. It's actually a bit higher than you would get in your supermarkets. So it's sort of medical grade bleach, and those sorts of products work quite well for coronavirus.
You are you're screening each patient on the phone prior to them coming in.
So I'm actually screening each patient as we are right now. I'm doing a lot of video conferencing, and and a lot of people are doing telephone, and really our message to physicians has been do whatever works for you and your patient, right? So if it's easier for that patient to receive a phone call, great. I think you guys could actually use a bit of telehealth as well, even just with something simple like Zoom. There's a lot that patients can show you. And I think it's that connection, right? So many people now are on self-isolation, and they really appreciate seeing a trusted and familiar face. I can't tell you how many people burst into tears when I come on the line because they've been stuck at home reading their Twitter feeds all day, so I'm sure there's a lot that you can assess, and there's some decisions that you can make, like this isn't ideal, like I wouldn't necessarily do that in a normal situation, but these are extraordinary times, and we're going to have to find creative ways to solve dental problems for people, or can they do something, like if it's a wire or something, is there something that they can do themselves? Yeah, just being a bit creative around that.
Yeah, so it's probably a good step today if the dentist is not doing it, they're seeing patients. It's fine to have your staff phone the patient to screen them, but you should follow up and screen it yourself.
To be honest, I personally, for the physicians, because the staff aren't trained around the nuances, right? Like you're the only one that's really going to figure out, does this patient really need to come in? So my staff call, and then I call, and then we call, we like we really screen, and people still lie, and people still steal our supplies, and it's you have to have those protections.
Two calls is good. Staff, then you.
Yeah, I think staff just for the basics, like have you traveled? Do you have a cough and fever? But then I think the clinical scenario, I wonder if you guys should be doing that, because you're making the decision, is this urgent or not urgent? And some things are obvious and the staff can make that decision, but there might be some nuances, like can you put them on antibiotics? Is there another option, right? So you might be able to be a little bit more nuanced in your approach to how you assess that over the phone than your staff.
Yes.
And by the way, our staff is not even in the office. So we're telling our staff is that I am the essential service, but our MOAs are not the essential service. And it doesn't mean that they're not essential, but it's not essential for them to be in the office. Mm-hmm. So my MOAs, we have all the phone calls are taken off-site. They are e-faxing from home. They're doing all, and I push a lot of paper in an average day. And we have managed, other than having someone in to do maybe a bit of sterilization after hours, really think about your staff as well. We had some elderly staff, like older staff who are in high-risk groups, and they need to be home, and they can be absolutely productive in helping you out. And I don't know how that translates into dentistry, but if you can manage to do a procedure without having someone there for assisting, that part I'm not as familiar with, but really think again, if I'm bringing the staff person in, and if I'm actually exposing the staff person to an aerosolized procedure, is it worth it? Is this procedure needed? Do I need the staff person to be here? So just starting to think in terms of really, really minimizing that risk.
The thing is, though, is there's more than one physician in your office. Is that right? Okay.
We only have one physician in the office at any time.
So you're alone in the office with a patient?
Sorry?
Be alone in the office with a patient?
I am alone in the office with the patient, yeah, with one other MOA. But these are known patients.
Okay.
Yeah, and we haven't come across it, but if it was someone that I didn't feel comfortable seeing, then yeah, that's a different story. But again, for the most part,
nobody demanded a remote interview with me.
Sorry?
Nobody demanded a remote interview with me.
Right.
But we'll see, the thing is with endo, we don't know them from a hole in the wall, right?
Yeah.
and so it's kind of nice to have other people there for
It
that.
is. And then I don't know if you guys have had the problem with supplies being stolen. So that's been very common across family doctors' offices. So like hand sanitizer, gloves, masks. And we're actually running out of masks. And so every mask is one person that's an emergency that could have been seen, because at some point, if we run out, we will just not have any access for them. They will not be able to go to emerge, and they will not be able to see any primary care physician, because I'm not going to put my doctors and staff in harm's way. So so we have locked down and fully inventoried all our supplies, because that's really going to be a lifeline going forward in the next few weeks. So if any dentists aren't working and they have extra masks and gloves, certainly you can reach out to your local family doctors. The health authorities have access to pandemic supplies, and the hospitals do end up getting more supplies. But for the most part, right now, community physicians have been left to source their own supplies, and we're pushing to change that. But right now, any help from the community is really helpful.
Mm-hmm. Yeah, no, absolutely. And there's also dentists can pool the resources into a few offices, which is helpful.
Yeah, actually that's a great idea. We're doing that a little bit locally, and then the idea is like, does every dentist have to go in like one at a time, or can we have one central clinic, so then you can have the deep cleaning and the physical, space. Like you have to really strip down your room so there's nothing, no surface that's superfluous, no waiting room chairs, sneeze guards for the staff if you have staff there. So there's actually a pandemic checklist for community offices, and I can forward that to you as well. And it kind of goes through the steps of how you should be bringing people in. So this whole idea of like weight rooming in the car and all that kind of stuff. So do you want to maybe have one or two clinics in your community that have set up to pandemic standards? And then either people are coming in or that person is seeing patients, and then maybe are you pooling the higher level protective gear like the N95s and the gowns and all of that. So it's a great idea.
I mean, I think that's great, and I think dentists should do it. And what I would suggest to dentists, you contact your local dental authority, whether it be the college in your area or the association, and share it with those organized bodies. This is I'm open these hours, these days, so then they can share it with other dentists, and maybe encourage. Up until now, dentists have been waiting for that to come from organized dentistry, but then maybe we should tell the organizations.
We found we just had to do it ourselves, right?
Yeah.
Like I think bigger organizations are scrambling, right? Like they've got their own fires. So the most work that we're doing is like boots on the ground, like just networks amongst physicians are probably getting more done than bigger organizations, because we can be a bit more nimble around that. So
inform them of the great work that you're doing so that they have
but it's definitely starting from the bottom and up. The other thing to think about is you are going to have dentists that are either high risk and absolutely shouldn't come in. Yes. And you have dentists that are going to be self-isolating or on quarantine and they can't come in. So how are you as a community taking care of their dental emergencies? Because they absolutely should not be coming in.
Any dentists over the age of 60, do you suggest?
I mean, that's sort of what we've said in our office. We've had a few staff and physicians that are either immunocompromised for various reasons or a bit older, and we've said we do not want you here physically in the office, and we'll keep you connected and we'll keep you busy. Don't worry. And so we do lots of little Zoom meetings with all the staff. It's actually been something that's really brought us together. So even though people aren't together in person, I think there's been a lot of connections made, because it's a stressful time. So people are reaching out to each other.
What about staff members who have someone immunocompromised at home, and so they don't want to come in for that, but you're kind of desperate to have that person in your office? I'm asking for a friend.
Sorry, the patient is immunocompromised, or
no, your staff member has an immunocompromised person at home. And so they're reluctant.
So the staff member has an immunocompromised patient at home. Yeah. I would not have them in. I would find something for them to do at home. Yeah. I mean, contacts of I mean, because everyone's going to be a contact of a contact of a contact. You can't like we do have to have some essential services. But again, I would argue, is that staff person an essential service? If it was a dentist that couldn't make any other arrangements, then when they get home, then they should be technically self-isolating from their partner. And considering, so we have a lot of emerge docs now that are not living at home with their family. They're living in an apartment or their basement suite, and they're having no physical contact with their family members for the duration, because the risk that dentists or physicians our risk is higher that we're going to be affected. And we may not get that sick, but we definitely have people in our life that could do. And just seeing this coming, I mean, we had already locked down our family. We've been social isolating before it was cool to do so. And the kids have had no contact with the grandparents for a number of weeks already. And that's hard on the grandparents. And we really are doing a lot of stuff through technology, but we recognize that we are higher risk of bringing something home that we could infect a loved one. So those are the sorts of decisions, right? And I think within dentistry, because the amounts of work that needs to be done is quite low now, like our work is almost like maybe a little bit less as we're deferring kind of non-urgent things, but we're pretty busy on the telehealth. If there's another alternative and that person can choose not to work, that would probably be my if that was a staff person of mine, that's probably what I would suggest, and see if there's anything they can do from home to stay busy.
Okay. Nitrous oxide machines. We shouldn't touch them.
Yeah, I heard about that. Yeah, because I'm not going to be an expert on that at all. But I know at the hospital, because they were talking about that in the obstetrics ward, I think they've actually gotten rid of their nitrous because of the risk of aerosolization. So I don't know what the safe guidelines would be around that, but yeah, Labor and Delivery has put away the nitrous oxide tanks. And then there's certain guidelines, and you guys can probably find it for you, but like what flow of oxygen is acceptable, right? Because higher flows of oxygen certainly can be aerosolizing as well. So if you're doing a procedure where somebody needs some oxygen, it'd be good to know what the recommendations are. And anyone in that vicinity, again, should be under full PPE.
Okay. Yes. 5 top tips. So you had to give 5 top tips to dentists.
Okay. Well, some general measures, and it's starting to sound kind of boring, but definitely wash your hands. The social distancing, I think as healthcare workers, we need to take that very seriously and at a higher level than most. Mm-hmm. Pre-screening, and I now that we've chatted, I actually think that the dentist should really pre-screen and make a very conscious decision about whether that person is coming in or not. 5. I wrote some down. Well, that was it. I think I just said 2 and 1. Yeah, social distancing for sure.
Well, teledentistry, be inclined to skip the clinical exam if you can, perhaps.
Okay, yeah. Like, if you're thinking like you can just maybe get the information off the X-ray.
Well, yeah. In specific, I had one lady come in, and she was referred by a dentist, and she had a toothache, and it seemed like pain. In all honesty, I thought it wasn't quite a dental emergency. Yes, it's toothache, but I don't think it was life-changing. But let's say it was life-changing. That's not really a huge factor. So I brought her in, and we did a comb beam machine, and then I had to go back out to the car park, and I said, just wait there, let me do the comb beam, right? Yeah. And I had to look at it, and this is one of the few times the comb beam was diagnostic. The root was cracked.
Right.
Like, go off and see the oral surgeon, have the tooth removed. If she couldn't see the oral surgeon in a short period of time, then I probably would have been able to pull the tooth for her. But I thought, well, it's great. Minimize that. And for me to do the clinical exam, it wouldn't have added anything to it. And it would just expose her to stuff, and it would expose me to stuff, and our staff to stuff. and we don't do it.
And
Whereas
you would,
months ago, that would have been malpractice on my part, but
mhm.
today it's pretty good practice. I would think. What do you think?
I think so. And then the other element that you need to think about is this full set of protective gear that you're using for this encounter, maybe someone else that you can't see later on because you've run out of supplies. So
Yes.
we're really starting to think about that as like not about the patient just in front of you, but again, we might be at this for months. So I'm thinking about the patient down the road that might be in more serious condition. And I have just burned through my supplies too quickly because I haven't been as careful with that. So it is a balance, and I think it requires a very an in-depth conversation with the patient about, like, again, ideally we would do this, but because of the risk we're doing that. And I think if you document the context, and be available for follow-up. So, in that case, if things changed and you were available and she wasn't able to get the tooth pulled, I think that availability of follow-up, I think that would be very, very reasonable.
Mm-hmm. Mm-hmm. Okay. Yeah. So that's another point. Well, I think we've covered a lot of great information, Krystine, and I know your dance card is really busy at the moment. You got meetings coming left, right, and center for you, right?
Yeah, I'm gonna start cursing virtual visit, virtual life. I'm doing about 14 hours of either seeing patients or at meetings, and I think I'm gonna have to surgically remove the phone from my hand when this is all over. So, but this was a lovely break. This I really enjoyed doing. So thanks for
Well, it
inviting.
was absolutely super fantastic having you, and the information's been absolutely wonderful. We will share also all the graphs and things you referred to when you're speaking to us. Also, if anything else crops up that you can think of, please send it to us. We'll post it on the PFX.
Sure. And I'm open to questions as well. So we're fielding a lot of sort of workflow questions from around the province. So we might, if someone has a question, we might already have that resource available. And I'm just realizing how important networks are right now. So if we wait for all of that to come from top down, it's sluggish. But if people have ideas and they can be in networks and share that, I think that's keeping people safe by disseminating information as it becomes available. So I'm also very happy to take some questions offline if they come up.
Excellent. Well,
Okay, great.
you couldn't do more. That was wonderful. Thank you so much.
Yeah, thank you. It was fun.
Yes, it was indeed. And stay safe.